Welcome to The Critical Edge, the no-nonsense podcast breaking down the latest game-changing evidence in trauma and surgical critical care to give you the edge when things get critical.
Always great to be here.
So, what is the very pill you prescribed to stop your trauma patient from, bleeding to death in week 1 is the exact reason they develop pancreatic cancer in year 2?
Yeah, it's a terrifying thought.
Right. Or what if the most advanced, insanely expensive vasopressor in your pharmacy is clinically useless just because you ordered it like 12 hours too late?
Timing really is everything in the unit.
It totally is. And, you are tuning in today because you are a United States-trained trauma and surgical critical care surgeon.
You're living in that high-stakes, high-adrenaline world.
Exactly. The ICU, the trauma, your ultimate goal is optimizing patient outcomes when the margin for error is, well, absolutely zero.
Zero room for mistakes.
Right. So today, we're setting out on a very specific mission for this deep dive.
I'm excited for this one.
Yeah, me too. We are looking at the life cycle of ICU interventions. Specifically, the precise moment to add them, the actual physiological mechanics of how to deliver them.
Yeah, and the part we always forget when to subtract them.
Exactly. The oft-forgotten discipline of subtraction. We've got 3 massive sources to get through today.
Some really practice-changing data here.
Yeah. First, we've got a retrospective matched analysis on angiotensin II for refractory shock. That's from Critical Care Medicine 2023.
Really interesting data out of Michigan.
Then we're shifting to the Savent randomized clinical trial on Sigh ventilation in trauma patients.
That was in JAMA, right? 2023.
Yeah, exactly, JAMA. And finally, a massive propensity score-matched cohort study on the morbidity of continued proton pump inhibitors, or PPIs, from Critical Care Medicine in 2024.
The scale of that PPI study is just staggering.
It really is. Okay, let's unpack this, because we constantly need to reevaluate these interventions that feel like just standard practice.
Yeah, I mean, the concept of an intervention's life cycle is really what separates baseline competence from true mastery in surgical critical care.
Absolutely. Because physiology in a textbook.
Right. It's totally different from physiology in a polytrauma patient. They are 2 entirely different landscapes.
For sure. In the ICU, you're constantly managing these complex, rapidly degrading systems.
Exactly. When you introduce an exogenous variable, whether it's a synthetic vasopressor, or a mechanically engineered breath, or even a targeted acid suppressant, the body reacts.
It adapts.
Yeah, it adapts and invariably compensates in ways we just historically didn't anticipate.
Right. So what serves as this life-saving bridge at, say, hour 2 of an admission?
Can seamlessly transition into a biochemical anchor, dragging the patient down by day 14.
That's such a great way to put it.
The evidence base is finally catching up to the sheer complexity of the multi-organ failure cascade. We are moving away from that legacy paradigm of, more is better.
To a reality where precision is survival. So let's start at the absolute bleeding edge of resuscitation, which is that initiation phase.
The pressor pivot.
Right. You are managing distributive vasodilatory shock. We all know the nightmare scenario at 3 a.m.
Oh, yeah, we've all been there.
You've got a polytrauma patient, massive transfusion protocol is initiated, and now they're showing classic signs of profound systemic vasodilation. The
capillaries are just leaking everywhere.
Yes, the endothelial glycocalyx is completely shredded, and the vital organs are just screaming for perfusion.
MAP is in the boots.
Arterial pressure is just gone. The lactate is climbing exponentially, and you are maxed out on norepinephrine.
You're just staring at the monitor.
Right, and the catecholmine pathways are essentially burnt out. The alpha-1 receptors are completely desensitized.
Endogenous vasopressin stores ran dry hours ago.
Exactly. This is the moment clinicians traditionally reach for the Hail Mary.
Enter angiotensin II.
Yeah, ATII. So to really appreciate the clinical data we're about to look at, we have to look at the cellular mechanism.
Right. Why does that specific moment feel so desperate? And why was ATII theoretically designed to be the ultimate rescue agent?
Walk us through that physiology.
Well, in distributive shock, particularly profound vasodilatory shock following massive tissue injury, the body's endogenous vasopressor systems suffer a catastrophic failure.
Total system crash.
Exactly. You mentioned the desensitization of alpha-1 receptors earlier.
Yeah, from the high-dose levo.
Right. When you are pouring high-dose exogenous norepinephrine into a patient, those receptors downregulate. The smooth muscle in the vasculature simply stops responding to the signal.
It just ignores it.
Yeah. But angiotensin II bypasses that exhausted catecholamine pathway entirely.
Oh, right. Uses the RAS pathway.
Exactly, the renin-angiotensin-aldosterone system. By binding to the AT1 receptors on the vascular smooth muscle, it promotes direct, intense vasoconstriction.
And it specifically targets the kidneys, right?
Yeah, specifically the efferent arterioles of the kidneys, which theoretically preserves glomerular filtration while also driving systemic fluid retention.
So it's a completely different mechanism of action, providing a rescue pathway when the conventional roads are washed out.
That's the theory anyway.
Which brings us to the actual real-world application of this theory. We are looking at this 2023 study by Smith and colleagues.
Out of the University of Michigan.
Right, using their DataDirect database.
Right.
And the objective was pretty straightforward, right?
Yeah, basically asking, does giving an IV infusion of ATI in these dire refractory situations actually move the needle on 30-day or 90-day mortality?
So they analyzed 813 adult shock patients,
And 271 of them received the IV ATII infusion.
while the remaining 542 patients were sorted into historical and concurrent control arms.
Right, receiving equivalent doses of non-ATII vasopressors. You know, standard stuff, norepi, vaso, phenylephrine, dopamine.
So how did they handle the baseline matching? Because that's the real crux of understanding these results.
It is. When you evaluate the raw data prior to matching, the ATII group was staggeringly sick.
I mean, this wasn't an RCT, right?
No, not at all. It wasn't a randomized controlled administration where everyone got the drug at the exact same stage of shock.
Clinicians were just reaching for it when things got really bad.
Exactly. The clinicians at Michigan were reaching for ATII for patients who had significantly higher SOFA scores.
Much higher lactic acid levels, I imagine?
Oh, yeah. Lower baseline mean arterial pressures, vastly higher rates of mechanical ventilation, and continuous renal replacement therapy, or KRT, right at the exact moment of enrollment.
So by all objective metrics, the ATI group was already further down the drain.
Considerably further down the irreversible spiral of multi-organ failure.
Which, honestly, mirrors the reality of a busy U.S. trauma center perfectly.
Oh, 100%.
You don't reach for the novel, highly expensive, specialized pressor when a low-dose whiff of norepinephrine does the trick.
No, you reach for it when you're terrified the patient is going to arrest in the next 10 minutes.
Exactly. But here is the critical analytical step. Smith and his team utilized propensity score matching.
Right, to adjust for those wildly divergent baseline characteristics.
They statistically leveled the playing field. So they were comparing apples to apples, right? Patients of equal sickness.
Yeah, they matched them up.
So once they did that,
No.
what did the bottom line on mortality actually look like?
Well, the adjusted data tells a highly sobering story about the limits of salvage therapy.
Give us the numbers.
After propensity matching, the 30-day mortality was 60% in the ATII group versus 56% in the control group.
And the p-value on that?
It was 0.292.
Wow. So not significant at all.
Not even close. And when you extend the timeline to 90-day mortality, it was 65% for the ATI group versus 63% for the controls.
With a p-value of what?
0.440.
Jeez. So in pragmatic statistical terms, those p-values indicate that any observed difference is purely statistical noise.
Yeah, there is just no significant mortality benefit.
And what about the secondary outcomes? Did it help with the kidneys or the lungs?
It gets more discouraging there, honestly. They track the need for new renal replacement therapy or new mechanical ventilation after the enrollment period.
Yeah.
Zero significant difference.
Really?
Yeah. The odds ratio for new KRT was 1.39, but the confidence interval crossed 1.0, giving a p-value of 0.158.
And for the vent?
For new mechanical ventilation, the odds ratio was 1.50 with a p-value of 0.539.
I mean, even the rates of thrombotic events were similar, right?
Yeah.
Which is a major known theoretical risk when you're using a potent vasoconstrictor.
Yeah, thrombotic events were totally similar between the groups.
I look at this through the lens of a surgeon standing at the foot of the bed watching that arterial line trace just flatten out.
It's a helpless feeling.
It is. And in this specific data set, ATII was utilized strictly as a salvage therapy. Like the absolute last resort.
Right.
Is using a drug strictly as a salvage therapy in refractory shock. Essentially like throwing a single bucket of water onto a house that is already burned down to its concrete foundation.
That is exactly what it's like.
I mean, by the time you're adding your third or fourth vasopressor, the microvascular derangement, the endothelial cell death, the mitochondrial dysfunction is just so entrenched.
Yeah, there is no molecule synthesized on Earth that could reverse that mortality curve at that point.
The machinery of life is already broken.
The physical mechanics of your burnt-down house analogy perfectly explain the physiological failure here.
How so?
Well, by the time you reach the salvage phase, the smooth muscle isn't just ignoring signals.
It's physically failing.
Exactly. The actual cellular structure required to contract and hold vascular tone is breaking down due to profound acidosis and hypoxia.
Right.
What's fascinating here is when you compare this real-world Smith study to the landmark ATHOS-3 trial, it really illuminates the issue.
ATHOS-3 was the big one, right? The trial that brought ATHI into modern practice.
Yeah. It's the foundational randomized controlled trial. But the architectural design of the ATHOS-3 protocol was fundamentally different from how the drug was utilized in the Michigan dataset.
In what way?
In ATHOS-3, when the ATI infusion was initiated, the protocol strictly mandated that it be maintained while the other vasopressors were actively weaned down.
Oh, so they were pulling off the toxic load of catecholamines.
Yes. The entire strategic goal was catecholamine sparing.
Whereas in the Smith study...
In the Smith study, ADI was just dumped on top of massive doses of everything else as a last-ditch effort to squeeze a dying vascular bed.
Wow. That is a massive distinction in clinical strategy.
It's huge.
It's the difference between replacing a highly toxic load of one drug with a cleaner, targeted alternative versus just piling more and more hemodynamic stress onto a myocardium that is already failing.
Exactly.
But
Furthermore, ATHOS-3 demonstrated a distinct mortality benefit specifically within a subgroup of patients who were receiving renal replacement therapy at the time of initiation.
And let me guess, that benefit wasn't in the Smith data.
That specific benefit was completely absent in the Smith study.
So this massive discrepancy between a highly controlled explanatory trial and a real-world retrospective database really highlights something.
It highlights a fundamental law of critical care pharmacology. The what is frequently less important than the when and the how.
The exact timing and the administration strategy dictate the clinical outcome.
Absolutely. If you use ATII as an early second-line agent to spare the fragile endothelium from massive catecholamine toxicity, you might save the kidneys and the patient.
But if you use it as a terminal salvage agent when the pH is 6.9 and the lactate is 15.
You are just treating the monitor while the patient dies.
Man. We do have to address the structural limitations of the Smith study, though.
Oh, yeah. We definitely should.
Because it is a retrospective, single-institution design. The University of Michigan is a phenomenal academic medical center, obviously.
Sure, world class.
But their specific patient population, their proprietary ICU protocols, their attendings' subjective thresholds for salvage therapies.
Yeah.
It might not perfectly mirror the realities across all U.S. Level 1 and Level 2 trauma centers.
That's a fair point. The retrospective nature of the data means we can only observe associations. We cannot prove causation. And because it's confined to a single center, the external validity or, generalizability is inherently limited.
Plus the unmeasured confounders.
Oh, always. In retrospective claims data, there are nuances of patient care that cannot be captured by a SOFA score or a billing code.
Yeah, for sure.
However, the limitation of it being a purely salvage therapy study is, ironically, its greatest strength for everyday practice.
Because it's a reflection of reality.
Exactly. It acts as a mirror, reflecting exactly how ATI is often desperately used in the wild today, outside of pristine trial conditions.
Right. So the ultimate clinical takeaway isn't that angiotensin II is a useless drug.
No, not at all. The takeaway is that waiting until the house is burnt to the foundation yields predictable, dismal results.
Okay, so that concept of early proactive intervention brings us perfectly into the second phase of our deep dive.
The maintenance phase.
Right. Optimizing ongoing support. We have just spent a massive amount of time talking about optimizing blood flow and hemodynamics.
But blood flow is completely useless if the hemoglobin isn't carrying oxygen.
Exactly. Once we have stabilized the pressure, we have to protect the lungs.
And in a polytrauma patient, the lungs take an absolute beating.
They really do. I mean, you're dealing with direct pulmonary contusions from blunt force.
Flail chest, rib fractures, completely impairing the mechanics of the chest wall.
And then there's the massive systemic inflammatory hit.
Right, the biotrauma of severe injury and massive transfusion protocols.
That systemic inflammatory hit, combined with the sheer mechanical physics of positive pressure ventilation, it places these trauma patients at an immense risk for ARDS, right?
Acute respiratory distress syndrome, yeah. Massive risk. And we have to look at the physics of the alveolus to understand why.
Okay, break that down for us.
Well, when you place a patient on a standard volume-controlled or pressure-controlled ventilator mode, you are typically delivering a highly constant, monotonous tidal volume.
With every single machine breath.
Exactly. But physiologically, that is not how the human respiratory system evolved to function. Spontaneous human breathing is highly variable.
We take shallow breaths. We take deep breaths.
And crucially, we sigh.
Right. The human body fundamentally rejects monotony.
It does. A constant, unchanging mechanical force applied to biological tissue usually results in necrosis or failure.
Exactly the case with the pulmonary architecture.
Yeah. In the lungs, constant, monotonous, low tidal volumes lead to progressive alveolar collapse.
Atelectasis.
Right, atelectasis. And this happens because the constant shallow stretching depletes surfactant.
And surfactant is that critical lipoprotein complex lining the alveoli.
Yeah. It reduces surface tension and prevents them from collapsing inward on themselves during exhalation.
So the theoretical physiological benefit of introducing mechanical sigh breaths onto the ventilator, like programming the machine to deliver an occasional maximal volume breath, is to physically stretch those type 2 pneumocytes.
Exactly. That stretch stimulates surfactant secretion, physically pops open those dependent, collapsed, sticky alveolar units, and ultimately reduces ventilator-induced lung injury, or VLA.
Which brings us to this event trial.
The JAMA 2023 paper by Albert and colleagues.
Yes. This was a pragmatic, randomized clinical trial, and the scale of it is what makes it so relevant to our listeners.
Right. We're looking at 524 patients across 15 different academic U.S. trauma centers.
Randomized in a 1-1 fashion. And the intervention itself was brilliant in its absolute simplicity.
It really was.
The respiratory therapist just programmed a sigh breath that produced a plateau pressure of exactly 35 centimeters of water.
Or 40 centimeters of water if the patient had a BMI over 35.
Right. And this single deep breath was delivered exactly once every 6 minutes.
While the control group received whatever the standard, usual intensivist care was at that specific trauma center.
Now, the classification of this as a pragmatic trial, that's the lens through which we must view all of these results, isn't it?
Absolutely. Explanatory trials, like the original ARNet RMA trial that established low tidal volume ventilation, they attempt to control every single granular variable in a pristine, laboratory-like clinical environment.
Just to see if an intervention works under absolutely perfect conditions.
Right. But pragmatic trials, like SIVENT, are intentionally designed to test an intervention in the messy, heterogeneous, uncontrolled reality of everyday clinical practice.
So they didn't dictate exactly how the control group had to be ventilated.
No, they just let the intensivists and the RTs at those 15 different centers practice their usual standard of care.
Which honestly makes the data significantly more applicable to the actual day-to-day practice of a surgical critical care physician.
Because we are constantly battling protocol drift and individual provider preferences.
Exactly. Okay, so let's get into the data. Because the primary outcome presents a really fascinating statistical dilemma.
It does. The primary outcome was ventilator-free days, or VFD, measured at day 28.
And in the Sigh ventilation group, the median was 18.4 VFD.
While in the usual care control group, it was 16.1.
So when they ran the numbers, the adjusted mean difference was 1.4 days in favor of the Sigh group.
But the p-value landed at 0.08.
Here's where it gets really interesting. It narrowly missed that magical, traditional, and entirely arbitrary mark of less than 0.05 for statistical significance.
Yeah, so strictly speaking, from a rigid methodological standpoint, it was a negative trial for the primary outcome.
But is it really?
Well, this is where surgical critical care physicians have to elevate their understanding of biostatistics beyond the textbook. In a pragmatic trial setting, it is a massive error in clinical judgment to simply dismiss a finding because the p-value lands at 0.08.
Let's break down what that number actually represents.
Sure. A p-value of 0.08 means there is an 8% probability that this observed difference of 1.4 ventilator-free days occurred completely by chance.
Right. And in an explanatory trial where every variable is locked down, 0.08 might be concerning.
But in a pragmatic trial across 15 different trauma centers, there is inherently a massive amount of noise in the data.
Because you aren't controlling the fluid management, the sedation practices?
Or the spontaneous breathing trial protocols. When you introduce that level of real-world noise, it inevitably dilutes the statistical signal.
So the power of the study might simply not have been mathematically sufficient to overcome the massive heterogeneity of what constitutes usual care across the U.S.
Exactly.
And the signal cuts through the noise the moment you look at the secondary outcomes.
It really does. Suddenly, that point zero 0.08 looks a lot less like a failure of the intervention and a lot more like a strong, vital clinical signal.
Give us the mortality numbers.
The pre-specified secondary outcome of 28-day mortality was 11.6% in the Sigh group versus 17.6% in the usual care group.
Wow. That is a massive 6% absolute risk reduction in mortality.
And the p-value on that mortality difference was exactly 0.05.
Plus, the Sigh group demonstrated a shorter overall time to successful extubation, right?
They did. This specific intersection of statistical reality and clinical utility is where protocols are born.
I mean, we are evaluating an intervention that costs $0.
It requires zero new equipment.
It takes a respiratory therapist approximately 3 seconds to program into any modern mechanical ventilator.
And in a high-risk trauma population, it demonstrated a clear trend toward more ventilator-free days, a faster trajectory to successful extubation, and a statistically significant reduction in 28-day mortality.
I want to focus on the mechanics of why you can have a non-significant result on ventilator-free days, but a highly significant result on raw mortality.
It's a great point to clarify.
Think of the damaged lung like a dense, flattened sponge, getting a non-significant result on ventilator days, but a significant result on mortality. It's like fluffing a pillow that has been crushed flat all night.
Oh, I like that analogy.
Fluffing the pillow doesn't necessarily make you sleep fewer total hours, which represents the total days on the ventilator, but the actual quality of your rest, the quality of your survival, is remarkably better.
That phallical analogy captures the pathophysiology perfectly.
Right. Mechanistically, by applying that 35 centimeters of water pressure every 6 minutes, you are dynamically recruiting the lung tissue,
You're decreasing the severe inflammatory shear stress, the Adalecc trauma.
which occurs when sticky, wet alveoli are forced to rip open and slam shut thousands of times an hour.
And by preventing that shear stress, you are likely saving the right ventricle from failure, which keeps the patient alive, even if it takes them a similar amount of total days to finally wean off the machine.
Because the actual mechanism of death in severe ARDS and villi is very rarely simple hypoxia.
Right. Patients don't just quietly desaturate and die. The mechanism of death is typically right ventricular failure secondary to massive pulmonary vascular resistance.
Or it's systemic multi-organ failure driven by the cytokine storm.
Yeah, the interleukins and tumor necrosis factor released directly from the traumatized shearing lung tissue into the systemic circulation.
Biotrauma.
Exactly, biotrauma. By popping those dependent alveoli open with a sigh breath and keeping them recruited, you are fundamentally blunting that systemic inflammatory response.
If we contextualize this within the broader literature, we have to look at the protection study.
Right, protection evaluated sigh breaths in a general non-trauma ARDS population.
And its primary contribution to the literature was proving that sigh breaths up to 40 centimeters of water were not inherently harmful.
They didn't cause massive pneumothoraces or barotrauma.
So Savint beautifully builds on that.
It does. It confirms this critical lack of harm in a highly specific, high-risk, often coagulopathic trauma cohort, while simultaneously offering a highly tantalizing signal for a true mortality benefit.
Now, a logical progression to the third and final phase of our deep dive. What happens when the patient survives the ICU, steps down to the surgical floor, and eventually goes home. But we forget to subtract our interventions.
Yeah, you are entering the highly insidious era of the polypharmacy hangover.
The polypharmacy hangover, I love that term.
And in modern surgical critical care, absolutely nothing exemplifies this pervasive problem more clearly than the routine use of stress ulcer prophylaxis.
PPIs.
Right. In the ICU, initiating a proton pump inhibitor like pantoprazole is almost a spinal reflex for a trauma admission.
Oh, totally. The patient is intubated, coagulopathic, under massive stress. You absolutely want to prevent a GI bleed.
But the guidelines generally recommend a maximum duration of 8 weeks for this prophylaxis.
And clinically, it should be discontinued much sooner once they are extubated and tolerating enteral nutrition.
But in the reality of the modern EHR, the dreaded click fatigue takes over.
Oh man, the continue button.
Medications constantly get clicked continue during transitions of care from the ICU to the floor to rehab without anyone ever entering a hard stop date.
The psychological burden of deprescribing is real. It is always easier to leave an order alone than to take the liability of stopping it.
Which brings us to this monumental 2024 study published in Critical Care Medicine by Palmowski and colleagues.
This study didn't just look at a few hundred patients in a single ICU to try and guess the scope of the problem.
No, they utilized massive health claims data from a major German health insurer.
They screened an absolutely staggering 591,207 adult hospitalized patients.
Just a massive, epic scale.
And from that initial pool, they methodically narrowed it down to 11,576 ICU patients who were initiated on PPIs, survived, but were discharged without a legitimate clinical indication for ongoing acid suppression.
The utilization of propensity score matching on a data set of this magnitude is what makes the findings so irrefutable.
Right, because when you are analyzing retrospective claims data, you have to aggressively account for selection bias.
Exactly. Patients who stay on heavy medication regimens might just inherently be sicker, older, or have more baseline comorbidities
Than the patients whose doctors felt comfortable taking them off the drugs.
So propensity matching essentially creates a statistical clone for every single patient.
For every patient who was left on a PPI inappropriately upon discharge, the researchers algorithmically found a patient of the exact same age, same comorbidities, same length of ICU stay, and same severity of illness who was successfully taken off their PPI.
This statistical isolation of the single variable unnecessary PPI continuation allows us to see the true isolated physiological effect of the drug over time.
And the raw numbers regarding the sheer volume of this error should terrify any discharging physician.
What were the stats?
In this matched cohort, 41.7% of patients were continued on PPIs completely unnecessarily.
Wow.
And almost half of those specific patients were left on them for greater than 1 year.
That is staggering.
We are talking about thousands of trauma and medical survivors wandering around in the community with chronically chemically suppressed stomach acid for absolutely no medical reason.
And this is where we have to look deeply at the morbidity data because the physiological fallout is profound, statistically significant across the board, and mechanically predictable.
Give us the odds ratios.
When compared directly to their matched counterparts, the patients left on PPIs had a 27% greater risk of developing pneumonia, an OR of 1.27.
Okay.
They had a 26% greater risk of developing chronic renal failure, an OR of 1.26.
Right.
They even demonstrated a 17% greater risk of major cardiovascular events.
Wait, really? Cardiovascular events too?
Yeah, an OR of 1.16.
And the cancer risks. Let me jump in here. The Palmowski data revealed a 2.7-fold increase in the risk of developing esophageal cancer.
An OR of 2.74.
And a 2.4-fold increase in the risk of pancreatic cancer, with an OR of 2.44, plus all the risks of D12 deficiency, hypomagnesemia, and hypocalcemia.
If we connect this to the bigger picture, it is a massive systemic failure of the transition of care.
The economic and physiological burden of this polypharmacy hangover is just astronomical.
It really is.
It's like leaving the scaffolding up years after the building is finished.
Oh, that's good.
Eventually, it starts damaging the structure it was meant to protect. Initially, that scaffolding was vital. But if you lazily leave it there, it rusts, it traps debris, it ruins the facade.
And eventually, the sheer weight and degradation starts fundamentally damaging the structural integrity.
Okay, so let's shift into some Q&A. Because an astute U.S. surgical critical care listener is going to have some highly technical questions here.
Let's do it.
Question 1 on the PPIs. How exactly does an acid-suppressing medication lead to a 27% higher risk of pneumonia and a 26% higher risk of chronic renal failure, according to this data? Walk me through the mechanistic theory.
Right. Let's start with pneumonia. The mechanism for the 27% increase is rooted directly in gastric alkalinization.
The stomach's acid barrier.
Exactly. The stomach secretes hydrochloric acid to sterilize the food we eat and the saliva we swallow. When you use a PPI to irreversibly inhibit the proton pump, you pharmacologically abolish that acid barrier.
So the stomach just gets colonized with bacteria.
Massive bacterial load, particularly highly virulent gram-negative rods. And in patients who have recently survived critical illness who might have subtle neuromuscular weakness causing silent dysphagia.
Or incompetent lower esophageal sphincters from prolonged NG tubes.
Right. Silent microaspiration during sleep is incredibly common. Instead of aspirating small amounts of sterile acidic fluid, they are continuously aspirating a high inoculum of gram-negative bacteria directly into the bronchial tree.
That makes total sense. And the kidneys.
The mechanism driving the renal failure is primarily twofold. First, PPIs are a well-documented cause of acute interstitial nephritis, or AI.
Right, which can smolder and cause chronic scarring if
Yeah.
unrecognized.
Exactly. Second, and perhaps more pervasively, is the issue of profound malabsorption.
Because you need acid to absorb micronutrients.
Yes. A highly acidic environment is essential for absorbing magnesium, calcium, and B12. Severe chronic hypomagnesemia caused by prolonged PPI use has been strongly linked to progressive endothelial dysfunction and the accelerated progression of chronic kidney disease.
Wow. Question 2. This one is on CIVET.
Okay.
Since the primary outcome of ventilator-free days wasn't statistically significant with a p-value of 0.08, but mortality was at 0.05, does this change standard EAST or ASCI guidelines tomorrow?
I would advise caution. While it confirms the protection study's finding of no harm and shows a promising mortality signal, the unblinded nature of the trial is a major limitation.
You physically can't blind event setting.
Exactly. You look at the screen, you know the group. This introduces performance bias. So it's a clinical pearl to consider for your specific trauma patients at risk of AR day, rather than a definitive blanket guideline shift just yet.
Perfect. Last question on ATII. If salvage therapy doesn't work, what's the evidence-based recommendation for ATII timing?
Based on the stark contrast between this Smith study and ATHOS 3, the recommendation leans heavily toward using it earlier.
First or second line?
Right. Use it to establish the MAP and actively maintain it while you actively wean down the other catecholamines, rather than waiting for refractory shock to set in.
So what does this all mean? Let's wrap up this deep dive.
Let's summarize it.
Number 1. ATII as a last resort salvage therapy in shock does not confer a mortality benefit. Timing is everything.
Number 2. Sigh breaths at 35 to 40 centimeters of water are safe in trauma patients and show a highly promising signal for improving 28-day survival and extubation time.
And number 3. We absolutely must deprescribe PPIs post-ICU to avoid massive, statistically significant increases in long-term morbidity and mortality.
The clinical takeaway for the U.S. trauma surgeon is clear. Be proactive with your ventilatory mechanics early, be thoughtful about the exact timing of your vasopressor initiation, and meticulously scrub your discharge medication lists.
This raises an important question. If an intervention as simple as removing a PPI can alter 2-year mortality by 20%, what other harmless routine ICU prophylactics are quietly causing a secondary epidemic of chronic illness in our trauma survivors?
It really forces you to look at that medication reconciliation screen in a completely new light.
It does. Thank you for joining us on this deep dive. Keep questioning the standard of care. Until next time.